Good morning, sir. Good morning, everyone. Thank you, sir, for the introduction. And after Dr. Priyanka and Dr. Darais, they've already taken the session to top gear. So I will be talking about an OCT-A way to look at the diabetic retinopathy, which is a very common case scenario in our OPDs. Is my slides visible?
Yes, sir.
Okay. So why is the angiography needed? So angiography is actually needed to assess the level of ischemia, to document the burden of proliferation, and to document areas of leakage. So when we are doing FFA, the conventional teaching is the early phase tells you about the ischemia, the late phase talks to you about the edema and the proliferation that one needs to deal with. Risks of FFA, that is all known to everyone, that it's an invasive test. So you can't keep on doing it again and again on the same patient. It's nephrotoxic, risk of anaphylaxis, and limited time, as in you have very limited time for the operator to catch a lot of information which would help in the treatment of the patient further. So OCT angiogram scores on this that it's an alternative method which is non-invasive, which is the most attractive factor. And the second thing is the time limit that the operator and the patient have is a little more compared to the limited time in an FFA. So what are we looking at when we do an OCT angiogram? In the retina, we are looking for capillary dropout areas, dilated and tortuous capillaries. In the choriocapillaris, we're looking for flow impairment of flow voids, phase changes for irregular contour or enlargement, capillary integrity loss, microaneurysms which are more appreciated in the deep plexus, any evidence of neovascularizations. The DME is seen as flow void areas in the deep plexus corresponding to the cystic changes. So this is, let us first see a normal to understand the abnormal then. So this is actually an enlarged view of the foveal avascular zone, as you can make out the anatomy so well here. Followed by an affected patient where the red marks the microaneurysms, which are seen as those dilated tufts. And you can appreciate how the foveal avascular zone is so enlarged and distorted, suggestive of ischemia in this patient. For these are actually images comparing the FFA with the OCT angiogram, the microaneurysms, the vascular loop, and then the enlarged foveal avascular zone with areas of non-perfusion. This is the green arrows are again showing you areas of non-perfusion. The red is showing you an IRMA and then the foveal avascular zone. And these are actually the artifacts which were spoken in detail by Dr. Priyanka in the earlier talk. This is another section showing a vascular front in a diabetic patient, which is again a segmentation. And as Dr. Darais sir showed in his previous slides, you can see the area of the vascular front showing it to be an active lesion. This is a patient of TRD this is the pre-anti-VEGF OCT angiogram, and this is the anti-VEGF after the anti-VEGF was administered. You can see the vascular caliber has gone down markedly, but if you can see the corresponding B scan, there is a little more noise happening here because of the mixture of the vitreous hemorrhage and the blood that was present under the hyaloid. So basically an Avastin injection is given pre-op to reduce the possibility of bleed that these patients have when you take these patients up for a vitrectomy to relieve the traction. This is another comparison of the NVEs that are seen. So you can see the red actually corresponds with the OCT angiogram of the FFA and the OCT-A, but the yellow is actually showing the areas of leakage which the OCT angiogram misses. So the peripheral viewing of the OCT angiogram and picking up of details can still be a limiting factor or a challenge. This is an image that which will show this is the clinical picture of the patient, the fundus FFA showing marked areas of neovascularizations with corresponding areas of non-perfusion. And this is a correlation of these areas of neovascularization with the OCT angiogram, where you can see these beautiful lacy networks and corresponding areas of capillary non-perfusion. So this was a classification proposed, which was published in the American Journal of Ophthalmology, which was the types of neovascularization. So type 1, which originated from the venous side and had a tree-like shape. Type 2 originated from the capillary networks, which are octopus-like shape. And type 3, where the irmas, which we know are the precursors of proliferation. So these were the NVs that originated from irmas and were C-fan in shape. This is another display of NVD. As you can see, this is the NFAS showing you the the neovascularization, active NVED with blood flow areas. And then you can see the pruning or reduce in the caliber of the NVD and a reduction in the blood flow areas post-treatment. These are again, so the picture, the ACE, these are basically irmas showing you the tuft-like projections, a magnified view with a projection above the ILM with the blood flow area. Treated it, the irmas have reduced in caliber, and the projection which was seen on the B scan has reduced and has gone sub-ILM. Another comparison to show the marked irmas with non-perfusion areas, the perfusion is returning post-treatment and the caliber of irmas is reducing. Another slide to highlight the same, where the irmas are reducing on treatment and the perfusion is improving. All this is picked up so well on an OCT angiogram, and you can actually document and show the patient, as nowadays seeing is believing. This is a comparison of again the FFA with the OCT-A, where this is the pre-treatment and post-treatment. So you can see post-treatment, the neovasc component has reduced, as in it was thick in caliber, it has become thinner in caliber, but the FA does not show you the areas of non-perfusion, which is still picked up quite well on the OCT angiogram. This is again of an image of a patient pre-vitrectomy and a patient post-vitrectomy, where you can see the advanced proliferation present along the posterior pole of the patient, which has obviously regressed post the vitrectomy. So to conclude, OCT angiogram, as has been already highlighted by the previous speakers, is the new tool in armamentarium of multimodal imaging, a non-invasive tool with comparable and reproducible results. It does have a learning curve where we need to understand how to get the image of interest, segment it well, and reduce the artifact component. Thank you.